Hello and welcome to our second of three-part series on scoliosis. My name is Amit Banti, and I'm Clinical Director and CEO of Comprehensive Prosthetics Orthotics. For all those who are joining us for the second time, welcome back. And for all our new viewers, welcome to this great panel discussion on scoliosis. As we all know, June is National Scoliosis Awareness Month, and we at CPO, as well as our partner practices that we work closely with, we decided to spend some time on treatment of scoliosis and management of condition, really to get a dialogue going, try to understand the condition, the pitfalls, the treatment options that are available out there, really to create awareness. Within the clinical community, patients, their parents, and public at large, because there's a lot of incidents of scoliosis that goes unnoticed a lot of times, and sometimes it's too late to do anything about it. So we decided to do this. In the last panel that we very successfully concluded last week, it was very interesting discussion, really bringing about the orthopedic surgeon's perspective on scoliosis. We had Dr. Lauren Mattini and Dr. Patel, as well as Dr. Kamal Ibrahim, who are all very experienced scoliosis and spine surgeons, who shared their ideas about scoliosis. The overall panel discussion was very well received. I also put forth a lot of my ideas and thoughts on scoliosis as a scoliosis clinician, things that we like to do and don't like to do, and how we approach the condition as a whole and our philosophy on treatment, right? But I think the biggest success was in everyone's consensus. A lot of times there's this discussion on balance versus correction, right? We all try to go after try to go after correction of the Cobb angle, right? It's the correction of the curve. But a lot of times you end up, creating an imbalance in, patient as a whole, right? So we all agreed that balance in a scoliosis patient is even more important than achieving all the correction. If you can get both, that's best, right? Overall, I feel that the discussion was quite successful, and the point that was driven home overall was team approach. How important is it to have an overall team treating scoliosis, right? From the family practice doctor who a lot of times discovers scoliosis in a patient, orthopedic surgeon, physical therapist, orthotist, and above all, the family and the patient themselves. So it was a point driven home. So in that spirit, the topic of today's discussion really is treatment of scoliosis, a team approach. So without further ado, let me introduce our eminent panelists to you guys. First, I have Dr. Ashish Patel. A lot of you know him from last week and otherwise. He's a very well-known scoliosis and spine and scoliosis surgeon from Chicagoland area, works at DuPage Medical and specializes in scoliosis. He has done extensive research in scoliosis and has published many papers and is an internationally acclaimed speaker on these subjects. Dr. Patel, welcome. Welcome back.
Amit, thanks for having me again. I appreciate the interest in the panel discussion. Look to have a great discussion again today. Can you hear me, Amit?
How you doing today?
I'm good. I'm good. Everything is good. Thanks for having me.
A little problem hearing you guys, as usual, my problems. Just 1 second.
Yeah, I can hear you.
All right.
Yeah, that's better too.
All right, perfect. All right. And the next speaker, we have our very own Tracy Melton. Tracy Melton, who's a regional vice president at CPO, Comprehensive Prosthetics Orthotics, and a member of our executive body from the clinical side. So he serves on our CPO's executive team. He has extensive experience in treating scoliosis and other pediatric conditions, and is passionate about scoliosis. Tracy, welcome. Thank you for taking time this evening, and we're excited to have you.
Yeah, thanks for having me. I look forward to talking with everybody and having a good discussion.
Great, great. Next, we have William Block. He goes by Bill Block. Bill, is a doctor of physical therapy. Practices at. Hey guys, can we have you mute yourself while we're not speaking, just so that there's some kind of background noise somewhere. There you go. Perfect. So he's a doctor of physical therapy, practices at physical therapy and balance centers. Bill specializes in physical therapy of spinal conditions, is SHOT certified physical therapist, which is a scoliosis specialty physical therapy protocol, and works very closely, with children and adults with scoliosis. So, Bill, welcome.
Thank you, Amit. Thank you for the introduction, and excited to be a part of this panel. Thanks for inviting me.
Thank you. Thank you for the time. And last but not the least, there's a reason I'm introducing him last, Dr. Miguel Gomez. Sometimes they say, keep the best for the last. Again, everybody's the best here, but I wanted to take a little time introducing Miguel. Miguel started his career as a trauma surgeon in Colombia at one of the largest trauma hospitals in Bogota. A family situation essentially changed the course of his life and his career, where his daughter at some point of his career got diagnosed with scoliosis. Miguel wasn't very happy, or I'd say frustrated with the treatment options available in Colombia, and came to the U.S. looking for better care for her, and essentially fell in love with everything that the bracing treatment and everything did for her. He fell in love with orthotics and scoliosis, and essentially made it really a calling. I mean, made it really a goal of his life to treat as many kids with scoliosis as he can. He became he went back to school here in the U.S., became a certified orthotist, MD certified orthotist, and he's an acclaimed clinician, international speaker, does regular clinics in the U.S., in Florida, in Bogota, Colombia, and Brazil, and anywhere else that they need him. So, we can say that everything that you went through, I think, was a blessing in disguise in many ways, because Miguel, we all gained an amazing scoliosis clinician. So welcome to the panel. You're muted, Miguel.
Okay, I'm sorry. Yeah, thank you so much, Amit. And this is a great pleasure to see young people. I am the oldest here, so it's nice to see that the new generations are taking the lead, and it's going to improve what we are trying to do now. So thank you, and I'm very happy to participate in your forum.
Thank you, Miguel. Thanks for everybody's time. So let's go ahead and get started, because we have a lot to discuss, and everybody has a lot to offer. So how about we do this? As we usually do, I'll just call on each one of you to maybe say a few things about your about scoliosis and your treatment philosophy. So how about we start with Dr. Patel? Would you like to get us started?
Sure. So, it's wonderful to see all the different facets of people who treat scoliosis here on, and that's really my approach to scoliosis care. We talked at length last week about early detection. So early detection is truly the critical component of having options for treating scoliosis. Being the most mild treatment would be just wait for watching observation, to then therapy protocols, including SHOT physical therapy, and orthotics if needed, when the concern for progression of scoliosis is at its worst during the adolescent growth spurt. So my philosophy for care is truly centered around early detection, and then once scoliosis has been recognized, having a team approach, having all the options available, and hopefully avoiding surgery.
That's a lot coming from a person who trained to be a surgeon. So we see that you really have the best outcomes and best for the patient in mind, and we appreciate that. How about you, Bill? Let's have you introduce yourself and your philosophy of care, and about on scoliosis. You muted, Bill. I'm sorry.
Yeah, so I was certified in the stroke method of physical therapy about 11 years ago. I studied up in Stevens Point, Wisconsin, under Beth Jansen, who studied directly underneath Dr. Manuel Rigo, who really took over the Schroth method that was designed and created by Katarina Schroth back in the early 1900s. And our approach and uniqueness to the physical therapy that the Schroth method offers is we're looking at the spine in a three-dimensional viewpoint and creating exercises that are developed to address the rotational components, obviously the lateral components, and what you guys had mentioned in the last panel, the balance of the individual themselves. A lot of times I won't even look at the x-ray first. I'll look at the person, look at their balance, their alignment, and then later confirm things through the x-ray and use that as kind of some helping guidelines. But really the Schroth method is about creating a customized program that addresses that individual's specific curve type. The severity levels determines protocols as well too. And then obviously complementing the brace program that they're in, the physical therapy program can offer some help there in possibly creating better flexibilities or adaptability to the brace that they're wearing there. So that's our ultimate goal for them to manage that process, like Dr. Patel said, of that early stage of, instead of kind of waiting and seeing and letting things develop, but really giving them something to grasp that they can control and start to work on and become independent in that process.
Great. Thank you, Bill. You touch upon two really important or very key points that we in our treatment methodology focus a lot on. And I think, at a later part of this discussion, we'd like to bring everybody back to that. One was flexibility, right? How to assess flexibility and how to measure. I know Dr. Gomez is big on that, as well as the planes, right? When you talked about sagittal, coronal, and transverse planes, and the idea that scoliosis is a coronal plane condition, but which plane is the first plane of attack in most cases, and I think I think it's something that we should all understand, especially for the clinician's perspective, and talk about that a little bit. Tracy, any starting comments? Any opening comments?
Yeah, just the I like hearing from Bill on kind of the kind of triplanar approach. We're looking at the overall patient's balance, trying to not just correct the cob angles, but really improve their overall balance and stability of their spine. It's definitely an important part of what we're doing. And we try to use the brace along with therapy, for stability of the spine and to really improve those curvatures and the patient's overall balance. We'd like to see when the patient comes out of their brace that we're hopefully in a better spot than where we started. We've got someone that's got better balance, better control of their spine. Hopefully better cob angles if things go really well. But we really want to use those kinds of tools and work as a team to really put that together and have that better outcomes.
Great points, and I think one of the points that we're going to discuss later on is visual documentation of or photo documentation of the treatment process and progression of the treatment, and because sometimes X-ray is not always available, or too many X-rays is not probably the best thing to do for the patients. So how do we document the process utilizing pictures? So I think that would be something that we'll discuss. Miguel, opening remarks.
Oh, thank you. Well, I have the luxury through a very tough situation, difficult situation. You can imagine having a child with scoliosis, and the end result is that we wait until all the doctors in Colombia and a few doctors from Latin America say, oops, it's more than 50 degrees, so she needs surgery. And we didn't do any treatment, just x-rays. Take an x-ray, come back in 4 months, and we will see. That was very, very sad. So I was saying that I have the luxury to go to Minnesota and to meet Dr. Winter, Lonstein, Ogoville, Bradford, the whole group 35 years ago. And I saw the value of the team approach. It's interesting that now we are still thinking that it's important. They have a team approach at Gillette Children's Hospital, Shriner Hospital, Fairview Hospital, and we have clinics, all the professionals together. So Dr. Winter, he was evaluating and he asked for the opinion of the orthopedist or the opinion of the physical therapist. And together, I remember that we developed the plan. So this is very important because in this moment, I think we are losing that possibility. And there is just a few doctors who are open to have the team approach clinic. It's not like I saw the patient and I sent the patient to you and you do this, but I don't call you about your ideas or what do you think? Do you understand? So this is very important, and I think we have to emphasize. And the second point is, I was really scary about the x-rays, and I saw my daughter increasing cosmesis very rapidly. And I was saying, well, if this is going to be worse, what's going to happen in 1 year or so? Thanks God that Dr. Winter said, Miguel, if I treat your daughter through the Scoliosis Research Society, she needs surgery, but she is still flexible. This is the first time that I hear that word. She is still flexible. So let's try the Milwaukee brace. And that brace and many other braces for 12 years, because she had infantile idiopathic scoliosis, did the job. Now she's 36 years old, no surgery. So it's beautiful.
Awesome, great, and we can hear it in your voice. I mean, it's a very personal thing for you, and I know your daughter very well. She now runs or helps run your Gillette Scoliosis Clinic, has a family, and all of those great things. So sometimes things have great outcomes. So happy for that. So moving on, I wanted to first maybe start with the prescription criteria, right? I mean, prescription of spinal braces. What are some of the things that, especially as a physician, right? What are some of the things that you're thinking about, when you're thinking about prescribing a spinal orthosis or a scoliosis orthosis for a patient? After evaluating a patient, what are certain things that you look at? What are certain things going on in your mind when you make that decision? Dr. Patel, maybe you'd like to take that.
Sure. So I see a fair number of children with either, so the patient gets sent to me initially for concern of scoliosis. Either they come with an x-ray or they don't. And there'll be a number of people that can potentially send me a patient. Either the family comes on their own, it's either the pediatrician who's seen it, and there's concern of it during an annual physical. There's either somebody who's been worked up and managed with brace wear through the years by a pediatric orthopedist, and they may get to a point where they're handing the care off. Either it's a severe curve, or it's got to that point. So prescribing a brace, let's say I'm early in the treatment course or disease course, and I have the ability, the patient is it's still in that growth spurt. So I'm thinking, how much growth do they have? And the ability to brace somebody and the need to ability to brace somebody is that, one, do I feel like I can stabilize the curve from further progression? Okay. So growth comes into it, and the location of the curve and the curve type comes into it. Okay. So we have to recognize whether these are idiopathic curves, neuromuscular curves, postural curves. Bill mentioned rotation as one of the calling cards of idiopathic scoliosis, and that's what we use to try to understand the types. And then location of the curve. And when I educate a family, when they're in that 20-degree, 40, 45-degree with growth remaining, and they're a great candidate for an orthosis, I'll counsel them to say, hey, thoracic curves are going to be better managed. Smaller curves are going to be better managed. The bigger curves with a lot of growth remaining, we're still going to try. Flexible curves are great to try. There are some curves that I don't brace that are high thoracic curves, cervical thoracic curves, because a brace, unfortunately, doesn't have the ability to control it. So those are some of the factors that I think about.
Great, awesome. I'll take the same question to Miguel. I think Dr. Patel made some great points, right, about stabilizing the curve, right? I think that's one of the first and foremost things that you want to do at the time of prescription, right? And then understanding the location, curve type, age. All of these are different things that you want to consider. Miguel, you also talk about alignment of the body at the time of prescription, right? So do you want to expand on what are some of the criteria that you as a surgeon / orthotist would like to see? I mean, or maybe create more awareness in the clinical community should be thought of or thought through in terms of prescribing scoliosis orthosis.
Please understand that I have two hats. When I am here on the States, I am a certified orthotist. When I am in Colombia, I am the doctor. And it is difficult to be like the chameleon, changing colors. But what I am seeing that is helping the most, I don't ask for the x-rays, even though the patient is giving me the x-rays. Here is the x-rays. I say, no, just wait. I want to see you. I need to take pictures without the clothes. Of course, you need to have like a swimming suit, or you have to have a gym clothes very tight, because the first thing that I want to understand is the alignment of the planes. And remember, the alignment is very critical. If the coronal is misaligned, if the coronal plane is misaligned, the transverse plane is going to have more rotation. If the sagittal plane is misaligned and coronal plane is misaligned, the transverse plane is going to have much more rotation. So we measure in millimeters the plane involvement. And that's why we say, in order to treat the patients, we have to create a protocol of treating plane by plane, but normally we start with the sagittal plane. If you don't unlock the facets, if you don't create posterior pelvic tilt to reduce the lordosis, to allow kyphosis, to reduce the kyphosis on the cervical spine, even though the x-rays will show you a great correction, that patient is not going to be stable. So the end of this is how stable is going to be the patient without the brace. I don't like to say, here is my brace, look at how much I reduce the curve. No, it's here is the patient without the brace, and this is the patient without the brace. How stable is the patient in the end of the treatment.
Makes sense. Are you suggesting that you're saying at the end of the treatment or at the start of the treatment?
No, you have the starting point, yeah. Initial evaluation, patient is decompensated 3 centimeters to the left, 2 centimeters. Sorry. Something happened here. Okay. The starting point, I'm sorry, that is coming up. Can you hear me, Ahmed?
Yeah.
Yes.
Yep. So I really don't put too much attention about the cup angle. I am more worried about how much the patient is decompensated to the left, decompensated anterior, rotation on the pelvis clockwise, rotation on the thorax counterclockwise, and so on. So we have to measure that in order to understand if we are aligning in the end of the treatment, the overall and intersegmental. You have to measure that information. So the result is initial evaluation with the end, without the brace. I am seeing that the people maybe the companies are competing. My brace reduce more than 100%. Maybe it's not necessary to reduce 100%. We need to reduce as much as the patient needs to be aligned and to be balanced and to be stable. I think
Makes
that's
sense.
it.
Great.
And by stable, I just want to clarify. By stable, I think what you're suggesting is the elimination of decompensation, right? To align the head and the thorax over the pelvis. Is that what you mean by stable?
Well, we always start with the base of support. We don't take just in consideration C7, S1. You have to start with the middle point of the base of support. The middle point of the base of support is the coronal center line, which is the most stable line. In this moment, we are not really using the plumb line. The plumb line is descending, the coronal center line is ascending. So we are looking for the coronal center line, sagittal center line, and transverse center line. So as I was trying to explain, if the patient is decompensated to the left or to the right, the patient will have more rotation. So you have to treat the alignment first to be able to treat the transverse.
So you mean to say that it's important to look at leg length discrepancy, or sometimes patients have varus of valgus in their ankle. So even before orthotic intervention or at the time of orthotic intervention, we should be looking at providing a heel or sole elevation, or some kind of orthosis for that. Dr. Patel, what's your take on that in your experience?
Yeah, I mean, there's often secondary causes of scoliosis, and leg length discrepancy is like at the top of the list, other than neuromuscular and stuff like that. When we take standing films and we take 30-inch cassette films, and then more recently we've been doing EOS films, so full length standing from head to toe. This each evolution of X-ray has given us more and more information about the overall patient alignment. We've gone away as spine surgeons from treating the 2D. Some of the things that have helped us do that is the evolution of, advanced imaging, whether that be EOS, whether that be surface topography, whether that, MRI or CT scan, just to gather some information. I'm not condoning that we CT scan everybody, but these studies have been done for us to better understand that. What I admire, obviously as a practitioner, I'm staring at these films. I garner sagittal plane, coronal plane, through asymmetry of the rib contour, through the the lateral sagittal alignment, and through the coronal alignment. So these are parameters that we use frequently, but you guys as practitioners or respective fields often look at the patient, ask them to, derobe, and then constantly reassessing your treatment and successive treatment through what Miguel was talking about, the overall alignment of the pelvis, the head, the thorax. I'd actually love to get Bill's take on this thing. Because,
Yep.
we often share a lot of patients with stuff. I'm sure we have each other's stuff, Bill has an amazing way of the way. And I know this is my comment.
So, Dr. Patel, I heard most of everything you said, but like the last probably 15 seconds was in and out there. So I apologize if I don't go directly off of your transition, but yes, to go along with what Dr. Gomez was saying and what you were saying, Dr. Patel, the primary thing that I look at, and it goes back to, I had mentioned that I don't even like to look at the x-ray to begin the process. It's really putting the patient in front of a wall grid that gives me some nice clean lines to look at. I do take pictures because visual feedback for the patient in the education process of the program is huge for myself and for the patient. And oftentimes in the first visit, when the patient sees that one shoulder is sitting, 2 inches lower on the wall grid, and then we do some self-corrections, and they realize that it's just a little bit of activation here, a little bit of tilt there, and they automatically grasp the concept that, wow, I can actually use my own body awareness and muscle activity to change center points or alignment points. And yes, it starts from the ground up. Whether we're using a heel lift or something, I don't always go quick there. I like to see what they can do and what we can do more actively first. And then if it's something where it's too drastic and an orthotic or a heel lift just makes sense. Because I've seen a lot of people with leg length discrepancies, but the leg length discrepancy doesn't match up with where their hip is sitting. The right hip's higher, but the right leg is shorter. So in those cases, obviously you don't want to put a heel lift in a shortened limb that the hip already sits higher there. But yeah, from the ground up and looking at those alignment points are the primary concepts that we work off of.
Great. Bill, I was going to come to you, but just to conclude this point, Tracy, you do an awful lot of visual documentation of these patients as we kind of go through the treatment process. What is your take on this, especially do these give you cues to maybe suggest a heel or sole elevation, doing something to the ankle, the coronal plane, and things of that nature?
Yeah, we're looking at the whole body a lot of times. We start off kind of what Dr. Gomez was saying, starting off really finding excuse me, where their overall alignment's at. Look at the coronal plane, sagittal plane. We look and document pictures through the transverse plane so that we can find where these misalignments are at. And we see some really unusual things sometimes, like Bill was saying, when you're looking at these things and they have a certain curve that if you look at the x-ray, then all of a sudden you have them bend or stand, and you're seeing rotations and kind of decompensations and things shift in areas where you may not expect that. So I think we're all kind of on the same page where a lot of us are looking at the patient overall and really taking a good close look at how their alignment is, where their rotations are at, where their asymmetries are at, where they're shifted off center in different planes, to really find out where these kind of
Asymmetries.
Asymmetries or deviations are really occurring, and find out they'll kind of compound on each other. So sometimes the foot or a leg length may be there. You may see some gingivalgum, or there's some kind of habitual things that patients have. They just always stand on one leg or the other. So really identifying these things and trying to figure out where these balance points are at is very important.
Got it.
To add onto that, Tracy, sorry, Amit.
Yeah.
That's something too that we see a ton of is looking at not just standing posture and alignment, but how it translates into dynamic movement patterns. You see so often the individual, doing something as basic as squatting or sitting into a chair, and they just kind of just rock right into that scoliosis deviation, or I see a ton of compensations, and then this lateral plane of either kyphosis or as Dr. Gomez was saying, a lot of pelvic imbalances of either anterior or posterior pelvic tilt. More so in the adult population, we see that the posterior pelvic tilt, where they become very, very kyphotic and collapse through there. In the adolescents, we see a lot of hyperlordosis, and balancing those things out is huge.
Got it.
I'd love to piggyback off that. So, to really truly understand where those imbalances are, because we're talking about balance, right? And true, like we're moving away from these static measures of balance, right? Initially, that was 2D imaging, and then it becomes 3D imaging, clinically or radiographically, and we're talking about functional understanding. And so we conducted a study. This was published like 4 or 5 years ago. But what we did was we tried to get a homogeneous group of idiopathic scoliosis. So we took the classic lanky 1A type with a right-sided convex curve, and all these patients were around surgical values of 45, 50, 55 degrees. Okay, so these were moderately to severe scoliosis. Okay, the reason why we took these patients was because when the curve type is that large, and forgive me for measuring in cob angles, but that's kind of a way to classify a patient. But the reason why we took these curves was because we wanted to understand what bad looked like. Okay, when you have subtle scoliosis around 10 to 15, sometimes these patients do pretty well, and sometimes clinically you may not even pick up any sort of asymmetries on the skin or on the actual shoulders, unless you have a very keen eye. So we took these patients and we placed optoelectronic markers on their shoulders, pelvis, thorax, knees, hips, ankles, head, arms, about 30 markers. And we make them walk across the room and back again over a force plate. So we can truly understand what's going on in the static aspect, but also on a functional aspect. And just like you're mentioning, Bill, these things that are intuitive to you from looking at your patient over and over again. But when you take 20 patients, and then these are the same preoperative, and after we did preoperative functional assessments, then we did postoperative functional assessments. Preoperatively, you start to see thoracic changes. Most of it's rotation, because a kid does really well at balancing themselves. Usually, you do see the head over the pelvis. There are some that decompensate. Those are really bad, and those are the ones to make sure that you get in and try to readjust and realign. But most of them do well in terms of balancing the head over the pelvis. But they always have this rotational component in their thorax, which then derotates their pelvis the contralateral way. And the way that they walk has been found to be pathologic in the sense that they don't go through the gait cycle like normal straight alignment people do. What the implications of this on a day-to-day basis is, it's hard to understand because I don't have scoliosis, but these are some of the findings.
Great. Guys, my suggestion would be for us to move ahead because we're going to run out of time. So one of the key points, and I think I'm going to direct this to Bill, in last week's panel discussion, we all talked extensively about, importance of physical therapy in scoliosis, right? And I think we all agreed that physical therapy is a key part of, overall scoliosis treatment. and a specific type of physical therapy that is required. So, we'd like to kind of pick your brain on that, on different aspects of physical therapy, what modalities are available, and whether a patient in most cases should ask a doctor at the time of referral to any kind of, or going to a doctor about scoliosis, whether they need physical therapy or not.
Yeah. Thank you, Amit. Well, going back about 11 years ago when I started the journey of learning the Schroth method and working with scoliosis, patients with scoliosis, I was literally knocking on doctors' doors, trying to educate on the Schroth method and the application of physical therapy with scoliosis. And I would see, patients far and few between. And they were mostly, mothers or fathers that were, internet searching what other options are out there aside from wait and see, or something that can complement the brace. So I'm glad to be part of this panel, because it's come a long way, and I think that physical therapy holds a very important role in all of these things that we talk about balance and alignment. And the Schroth method is designed to do exactly that, looking at those imbalances, understanding scoliosis from that three-dimensional approach. With full transparency and PT school, there's not much discussion or education on scoliosis. It's pretty much a quick, this is what it is. Standard of care is if it gets this bad, they go into a brace. If it gets worse, they are a surgical candidate. Any questions moving forward there. So it is something that, if somebody is seeking out physical therapy for a child or even an adult for that matter that has scoliosis, I do recommend highly having somebody that has a specialized approach to the Schroth method for that.
No, can I ask you a question?
Yeah.
So from the time of your education 11 years ago, and from the time of my education, I go through renditions of learning and refining my technique. Maybe it was open to MIS and all this other minimally invasive surgery and so on and so forth. But the idea is to become better at your craft, right? To assess and reassess. How has Schroth changed over time from the time when Maria Schroth came out with it to your mentor or the mentor that you had, and then to you? What goes on in the evolution of that technique?
Yeah, that's a great question. That's a very tough question, Dr. Patel, I have to admit, because I am relatively obviously new to it, being that it was a process started back in the early 1900s. So I really can't go back and look at, experience what the programs were like back then compared to now. But what I can say is that more research has been done to kind of back and provide evidence that having a applied three-dimensional approach that the Schroth method offers gives patients better outcomes. And then you couple that with a bracing program, and the outcomes are even better.
Would you mind, maybe Miguel, with your experience with Schroth, extensive experience with Schroth, would you like to take Dr. Patel's question, or
Yes.
maybe have any ideas on that? Yeah.
Yes, actually, I want to say something first. If we really are going to do a team approach, we have to follow the protocol. So the whole team has to follow one protocol. And we have to understand my role in the team. So in order to do that, we found that the mechanical imbalance, 2 centimeters to the left, the brace, shoelace, UCVLs, AFOs, whatever you need to fit to the patient, are going to treat the mechanical imbalance. That's it. But if you don't treat the muscles properly with a three-dimensional approach, scientific method as Schroth, CS Barcelona rehab method, or a Lyon method, you will be failing because the patient will have a weaker muscles if you don't do the treatment. So the mechanical imbalance of the muscles, the mechanical imbalance you treat with the brace and the external devices. The muscle imbalance you have to treat with scientific methods of scoliosis as shroud. So in Colombia, I was having a good results, but many patients, I have a center there for 33 years, and I was happy with the results with the brace on. But as soon as we took the brace, the curve went back, and I was, oh my God, we have to train at least one person in Colombia with strut or CS. Thanks God that now we have a few people, and they are doing a great job. So the results that we are seeing now are fantastic. So that is really, really important.
Great. All right. I have one last question before we move on from this topic, and I'll direct this to Tracy, because this is, Tracy, we in our practice, we work for the same practice. We see a lot of physical therapy. Again, wait. So before I ask that question, I just want to comment on Dr. Gomez. That's where I think we feel a little lucky, even though we all work for different practices. We have a fairly good team here, between Dr. Patel, Bill, myself, Paula, where we have a lot of communication. We actually have a chat group that we chat different times, and a lot of communication. I think that's what's yielding very good results. So what I want to say is, even though we don't have those so-called ideal situations like Gillette Children or Fairview or some of the hospitals, clinicians who are, who want to do it, right, within confines of the commercial arrangements within their practices or the needs, I think we can do it. We can, have a very good team approach. And that's what I want to talk about here in this panel, because in most cases across the world, we don't have those ideal centers. People are working through, private practices, but also have really good intentions, and the best things in mind to treat these patients. So I think, I think we feel very lucky in that respect. Again, going back to my question to Tracy, in our practice, we see an awful lot of patients who are sent for orthotic intervention for scoliosis. A lot of times I find that there's no physical therapy referral, there's sometimes when there are, right? So what is your usual approach with that? Do you make that recommendation? Do you talk to the patient about it? Ask them, to go back and seek out a referral? And how often does that work? How responsive to that question is some of the physicians that you work closely with?
Yeah, it's an interesting situation. I know you're somewhat aware, kind of in our just geographical location, there aren't, I believe now we might be up to 2 maybe therapists that are actually trained or have had experience in the trough method. I'm in Central Illinois, just for reference. There's just not many around. So a lot of some of the orthopedic surgeons and stuff that we work with have not been as familiar or have not had good results because they don't have any direct scoliosis therapy programs to really refer people to. So there's a bit of a lack of therapy, or it's a newer thing. There are some people that are working on getting trained now. It's definitely coming around more, which is good. So yeah, different geographical areas, I've seen some different responses to that. I think everybody feels the same way, that therapy is a key component into really having the most success with with scoliosis treatment. But without the proper team or people to provide that becomes difficult. But we are seeing a lot more of that. I've talked with a lot of patients' parents that are very interested, kind of what Bill said earlier. Some people that a Google search of what other treatments are out there, what other options are there, and that therapy is always a part of that. So it's very we feel it's very important, and that we try to work with the referrals as much as we can, or talk with parents about the education of physical therapy that's really scoliosis specific, because
Got it. Yeah.
same with Dr. Gomez. If you're not all on the same page, doing the same kind of treatment with the same kind of goals, you're you maybe spinning your wheels a bit and not really, having the outcomes you're looking for.
I would say that to your point, Tracy, that physical therapy is probably the most important aspect of that initial scoliosis, and for the majority of scoliosis people, because I think it gives them an ability to learn about their body. And sure, orthosis is a great adjuvant to try to stabilize a curve, as Miguel suggested mechanically. If we that window of opportunity presents itself within the critical time, but physical therapy teaches them. I prescribe the physical therapy, the Groff method, more often than I prescribe the brace. And the reason for that is more people are indicated for the physical therapy, whether it's because of a progressive curve, a curve alone, a curve after skeletal maturity, pain, and then just understanding their body or even conditioning. So a lot of inactivity on the pediatric side these days, right? So I think it's critical for them to learn about their body, condition their body, learn about their scoliosis, embrace their body.
Great. I'll keep moving on. We're running out of time. It's these discussions always become very interesting. So what I'll do is there's certain other key points that we always get asked about, and I think there's a lot of interest out there. One is questions that we get asked, from the parents and the kids, right? How often, how many braces am I going to need, right? I mean, especially in terms of brace treatment. In terms of therapy treatment, what does a therapy protocol look like? How many visits typically, and once the treatment's done, what kind of follow-up should be maintained so as not to fall off, fall through the cracks, things of that nature. And also X-ray protocol. So maybe we can start again with the X-ray protocol. First X-ray, in-brace X-ray, and all of those. Maybe Dr. Patel, you can start with that because that is where it all starts. Because patients a lot of times ask me, hey, do I need an X-ray? Do I need to call back and make an appointment? And it many times it goes by the protocol that a certain orthopedic surgeon prefers to have. So just to set the base, right? I mean, what is your protocol, that you follow or is generally acceptable protocol for X-rays? If you want to comment on weaning off protocol, at what point, and then I'll have Dr. Gomez comment on some of that, Tracy, and then Bill, you can end that discussion if that's okay, talking about physical therapy and the whole protocol there.
Yeah, I mean, so let's say that we have the right patient who's being caught early enough, within that 20 to 30, 40 degree range, carb angle. Again, in this discussion, we're talking about metric focus radiograph, course alignment, the difference maker, but talking about standardization and understanding when these moments are by a protocol, carb angle is the number one thing. AVR and understanding the vertebral rotation based on thoracic curve, I think is very critical too. It's usually a trigger when we start to refer patients. You can't see carb angles clinically, but you can see AVR, which is able to rotation. Scoliometer, anything more than 7 degrees, usually initiates referral. Okay, so when I see the patient and the patient is indicated for a brace, and I immediately write them for an orthotic, a TLSO orthotic, and you guys do an amazing job with it today. And process. I counsel the patient as to the importance of brace wear. We have really good data now that brace wear and Schroth physical therapy are critical components to stabilizing and even correcting. So the end goal on an orthopedic end is time or likelihood of surgical management. These may not be the end goal for you guys to save surgery. In fact, you have different metrics and measures of success, which we should all share. But for me, I make sure that we have strong patients, conditioned patients, that does progress. Once they have their orthosis, they come back for an X-ray. So that's an in-brace X-ray, and they've at that time have ramped up their brace wear several hours each and every day to get to that critical threshold, 18, 20, and sometimes people are even passionate, enthusiastic about it, the 22 to 23 hours. At that time, I make sure it's pushing the right way, fitting the right way. It's not too tight, not causing any abrasions, and that again, we educate the patient and their family to wear that brace. Then I'll see them every 6 months for an out of brace, making sure that I document the RISA sign, how much, where they are in their skeletal growth chart, where they are menarche, post-menarche, how tall they are versus their parents and their siblings, to get a measure of how much growth that they have remaining. And then the weaning off period generally is after RISA 4+ or 5. However, there's some new data to suggest that curves even grow after. So it's a very touch and go thing. You got to get a feel for it about a lot of parameters, about height, growth, all that stuff too. That's my general.
Got it. Miguel, any further thoughts on that?
Yeah, I believe that I always say, please present to me the case first, and then we can discuss the whole protocol and the treatment plan. So I come from a country that it doesn't have a lot of sources. So I would love to have EOS, and I will do that study for every single patient, but it can be. So 3 years ago, a little more than 3 years ago, we developed a system besides the pictures with a grid, with lasers, to understand the imbalance, to understand the rotation, and to measure every single plane. We are using a scanner, very, very not too expensive. It's an iPad, is the structural scanner. And as Dr. Patel, I was very happy to hear that maybe we are using the same electrodes or the same markers. So we put one marker here on the shoulder, the other one, the ASIS, on the sacrum, on the center of the knees, on the ankle joints, wherever you want to put the markers, it has to be both in both sides. So we scan the whole patient. I'm sorry that I can't show you that, but maybe next time. And we develop a system to measure the planes through a scanner. So we have the overall scanner to understand the deformity, but also we train the patient to manipulate, to distract, to derotate. And then we call that the corrective shape of the deformity. And we scan the corrective shape. So we are using that technology, and it's being very interesting. I know that Tracy and you, are doing a terrific job. You are now, I don't have more gray hair because you are sending the cases properly. And it is very, very nice to see that when you send pictures with the braces that you are fitting, the brace fit properly. The brace is aligning first, and then reducing curve. So that's our first goal. Align and then reduce the curve. In order to use the flexibility factor, which is the key point, is the best player. If you don't use the flexibility factor, that factor, it can increase the deformity. So you have to be sure that you are approaching the flexibility factor, increasing forces, closing the brace, and then you will be taking the x-rays 6 to 8 weeks after the initial fitting, and every 4 months after that without the brace. It's just one x-ray with the brace on. That's our protocol.
Perfect. So I think very similar to what Dr. Patel said, right? Making sure that the brace is fitting tight and not causing any abrasions and things of that nature. Once the optimal fit is gained, then you do the X-ray. What about the weaning off protocol? When the time comes when the doctor says, "Hey, you don't have to wear the brace anymore," right? A lot of times they think from the word go that it's all good and they don't need to wear the brace. So thoughts on that? Whoever wants to go first.
Well, let me go first. To me, that's the most difficult part of the treatment, because I am seeing a great result, but I am afraid that if I take the brace off, that great result is going to come back sometimes more aggressive, and sometimes can go to the initial measurements, and sometimes the patient will be decompensated and maybe more decompensated than the initial evaluation. That's why we always take pictures every 4 months, pictures with a laser. We take scanners just to be sure that the patient is well aligned. That is telling us that the patient, if the patient is doing a good therapy program, a short program, the patient will remain in a stable position. We reduce the brace very gentle. That means if the patient was wearing the brace 20 hours, we reduce 2 hours the first month, then 4 hours the second month. So that means 2 more, to the point that the patient will be wearing the brace just at nighttime. So the weaning of the brace sometimes take 6 months to 1 year. It depends on the case.
Got it. Great point. Dr. Patel, any thoughts on that?
Yeah. I mean, I think that's a good protocol. I think, the idea behind it is that every child is probably very eager to try to rip this brace off and never wear it again, right? So you have to balance that. And the moment that you mention have any inclination that you're about to free them of this, they're going to take it and they're not going to turn back. So you have to be careful with the words that you choose, and regarding that team approach, that everybody is consistently saying the same thing about what their expectations are about removing the brace. So to Miguel's point, I think that you can turn something that's going well into something that doesn't look as well at the end. But, one of the questions, and we're probably going to save this for another time, is what do we truly think that we're doing, right? So let's say we see a 10 or 11-year-old and they're bracing and doing Schroff physical therapy and they're 13, 14, okay? Are we changing the viscoelasticity of the spine? Are we actually changing the morphology of the vertebra and the disc? And that's the reason why they don't progress or they progress? Because these have implications on whether you remove the brace and they're okay or they're not okay. So if the morphology of the vertebra doesn't decompensate further, then you should be okay removing the brace and we're good, right? But that's the critical understanding behind whether or not we've actually succeeded in changing anatomy. So it depends how our philosophy is and what we're actually working towards, what our objective is. And like I said, we can save that for another discussion, but I'd love to hear every one of our perspective about what we feel is actually happening on the end.
Who wants to go first? Bill, take that.
Yeah, if you don't mind, it brings up a great point, Dr. Patel, and it's a big part of the Schroff method that I haven't really touched upon yet is, our goal is not just the physical aspects of changing alignment, but it's also the reference point. So their mental imagery, their visualization, their understanding of this is not centered, this is centered, seeing it, repeating it, muscle memory. So kind of changing that neuromuscular input so that if we do fail in the realm of actually changing some of those physical aspects that you talked about, at least we can have a possibly a better body mechanics, better longevity to their spine as an adult? Are they, again, back to being kyphotic or lordotic, creating improper movement and body mechanics that lead to injuries later on. And it goes just as well towards aligning the spine as best as we can and creating symmetry within their postures and their ability to maintain that.
Tracy, any thoughts on that? Sorry, go ahead, Miguel.
Yes, Dr. Patel, this is a very, very important question, and that's the one that I want to answer to myself and be able to answer to the patient. I can prove it, but through many, many years of seeing patients, because I am a clinician, I love to be a clinician. I believe that we are facing a soft tissue deformity more than a bone deformity. And the treatment that we are doing is to retrain the muscles, the ligaments, the tendons, the disc, and everything that is soft tissue. So we have to understand two things. Elastic factor, that is the factor that when you compress the spine properly in 3 dimensions, you are able to reduce the deformity and you say, wow, look at that, that's great, beautiful. Well, that's not the whole treatment. You have to invite the plasticity factor, which is the one that if you take a fiber and elongate the fiber, then the fiber is going to be longer or shorter. It depends on what you are doing. So that's why in Colombia, we started treatment with physical therapy, with the shoe lips before the brace. We need to increase the flexibility factor. Sometimes when the kids end the treatment, the brace did a good job because reduced the curve, ask the patient to rotate, bent over, or lateral bend. They are like mermaids. They don't have a good range of movement. So I believe that we have to be careful with the muscles and the soft tissue.
But I think also what Dr. Patel talked about, that once the morphology of the bone is established, then what can you do, right? I mean, that's when.
Yeah, but that's exactly the same what is happening with a Sherwoman kyphosis. So if you have 3 vertebrae and they are compressing, but you do a good bending moment, it's not 3-pointer forces, is how do you change the tilts on the top and the bottom, the curves. It's not how much force do I put on the middle. It's how do I untilt the top and the bottom. So I have several patients that they reconstruct the bone and then it is as a normal vertebra after the treatment. So it depends on how do you do the biomechanical approach to the curves, if it's scoliosis or if it's kyphosis or so.
Got it. I think we're almost out of time. Actually, we've gone over a little bit, but the discussion's been extremely interesting. But I do want to, invite Bill to talk about the treatment protocol, the number of visits typically, and follow-ups thereafter that they like to have with physical therapy. Before I ask that big question that I ask every time, to conclude our session for today.
Sure, yeah. Just a typical protocol when, kind of baseline, I guess you could say, is patient comes in for initial evaluation, and based on where they're at in their process of if they've already started a bracing program, if they've seen Dr. Patel or another spine surgeon already, that all comes into play because if they're coming to me after seeing a physician or a spine surgeon, it's typically because they are appropriate for the Schroth method. But sometimes I do get individuals who come in who are avoiding seeing the doctor. They haven't had an x-ray, but I can just look at them and say, that's 50 plus degrees. And now we're thinking that maybe the Schroth method isn't the first step. You need to go get an X-ray. Need to go get checked out there. So, but once we establish a plan of care, it typically entails once a week. We meet here in the clinic once a week, and during that time, building an exercise program for their specific curve type. Maturity level comes into play there as well too, in the sense of how long we typically see a patient, because they have to become independent with their program at home and doing some daily work. So that can be harder or easier for some, depending on their support system, their maturity level, their dedication and commitment to it. So typically about 8 visits for a person to get to that point of being competent in their home program and showing accuracies with that. When they hit that point of whether it's 8, 10, 12 visits, that point where they've demonstrated that ability, then I always like to have a 2 to 3 month trial period of them just doing their work on their own at home. And that time usually coincides with when they're going for a follow-up X-ray, so it works out well. And I'll tell them to schedule after you have your follow-up doctor's appointment, so we can discuss where you're at in the Cobb angle scheme of things, and also check in to see how you're doing with your exercises, make sure they're still doing things correctly. If they come in and things are going well, curve has improved or staying stable, they're demonstrating the ability to run through their exercises with excellent form, then I talk about, okay, keep it up, keep going. Call me if you need anything, or call me if anything changes. If there are drastic changes where things have worsened, maybe we'll add some different focus points for them. If it's progressing rapidly, then I oftentimes do kind of go to some of the physical therapy interventions that are applicable to soft tissue issues like cupping or ASTEM, myofascial release techniques, see if we can dig a little bit deeper there. And then as for kind of weaning away, like once the person kind of hits that skeletal maturity point and Dr. Patel or Dr. Gomez has said, okay, you can stop wearing your brace, I really highly encourage them to continue doing their exercises on a regular basis. Yep. But also too, continuing through their lifetime on not a daily routine, but incorporating some of these exercises and breathing techniques into their daily workouts. If they're a yoga person, or if they're go to the gym and lift weights, mixing in some of this stuff. So never really truly forgetting about it or stopping it, and continuing in that aspect of it.
When I was speaking to you the last time, Bill, you brought up a great point that you tell your patients, to always bring their brace if they're going through a brace treatment to your visits, right? I mean, so they typically see the orthopedic surgeon every 6 months. We see them every 3 to 4 months, but you see them a lot more. And I think that's a great point, and a great point making this whole team approach work better, right? So what is your intent when you ask them to do that? What do you...
There's 2 things there. One, obviously the physical component of it, of seeing how they look in it, not to double check your guys' work, but to make sure that they're wearing it correctly. I've seen people come in and put their brace on wrong, and then I question, are you really wearing this? Like Amit and Tracy instructed you to. But the second part of it is, because usually most of the patients are doing a very nice job, and I compliment them on committing to it, because I know it's not easy, and it's a talking point to really show respect for them and their dedication, and praise them for their commitment to wearing something like that and committing to exercises that we're doing. But then also too, to really have them help with the buy-in of the whole aspect of the physical therapy is going to help the brace is going to help the physical therapy, and both of these things are going to help you in the long run. So it's, I really, to your point, bring the team approach into it of reassuring them that the brace has to be worn if it's going to be effective, and therapy has to be done if it's going to be effective. And yeah, so.
Very, very cool. So, I think that brings us, to the end of the session. But before we end, we always have this big question. So for today, and I apologize if I'm putting you guys on the spot, but I'm going to share a couple of pictures of a patient that we're seeing in one of our clinics. As a matter of fact, Tracy will talk about the patient. I'll share the pictures, and then we show the X-ray, and it's throwing a curveball at us. And I thought, what better time than to ask you experts as to what may be happening with that patient. So I'll share my screen. I'll take a couple of seconds of and show the X-rays, and then show the pictures, then the X-rays while Tracy talks about the patient. Is that all right?
Yeah.
Good with me?
Go ahead, Tracy. You want to talk about the patient?
Sorry. So the patient, whenever the pictures come up here, I believe a 13-year-old male. As we first saw him in January this year with an order for a scoliosis brace. It's I believe a right thoracolumbar curve. Don't remember the degree. I think it's like 23 or 27 degrees. So it's kind of right in that treatment window, for bracing. We ended up, we saw the patient. We, kind of evaluated the spine. Let's see what we have here. So yeah, that's the initial picture, on the left there from the initial evaluation. So you can see the patient really fairly balanced, doesn't look like anything major. You look at it closer, you can see some of the rotations that are happening. None of them look super severe. The shoulders are fairly symmetrical. The head is balanced. He's not, pelvis looks, kind of uniform and stable. But there are some little deviations you can see. Sorry, the little waves in the picture are just from the computer, but those throw things off a little bit. But there are some asymmetries there. And then, when we see the X-ray, I guess we can see that picture on the right is the initial delivery appointment fitting of the brace. So we've actually elevated that right shoulder at that point, which sometimes I'll see that.
Operative.
Yeah, and I may leave that a little bit until I see that X-ray. I make sure that we've got things in the right spot, and we'll make some adjustments on things. And then that picture here, this is our first follow-up. So he's been pretty sure he was the one that was doing therapy. I'm not sure if it's with someone that does the stroke method or not. But we had made some adjustment to the shoulder after seeing the X-ray. And so you see he's much, still very balanced, which he wasn't before. But then when we see the in-brace X-ray, that gives us a really good indication, kind of, along with the curve, just what that brace was doing for him.
So let me share the X-rays real quick. Are we all good with that? I brought up the pictures because we use the X-rays, but that's not all we do. So
yes, we do both. So this is like I say, a single curve. It's not as generally as complicated or easy or hard to correct if we've got good flexibility with the patient and good compliance with the with therapy and with bracing. So the original X-ray, if we see that it's kind of your typical thoracolumbar curve. He doesn't really have much tilt to the pelvis. There's not a lot of deviation of the lumbar spine. There is a little bit, but not a lot. And then
the X-ray should be coming up here shortly.
Sure. And then, so that'll be, so there on the left, there's the initial X-ray. So he is, like I said, he's fairly compensated, when you see the picture, but you can see some of the, like we saw in the initial picture, there's a little rotation, to the cervical spine and upper thoracic. So his head is a little rotated when he's standing, but there's very minimal asymmetries that you see in the picture. So, and then our in-brace X-ray, we've got really good correction. He's, balanced and straight. We see that shoulder that's elevated, so we made some adjustment on that on the brace. And then recently, just the other day, I got these two pictures from the doctor and wanting to know like some just kind of thoughts like what should we do here? So all of a sudden, for some reason, his in-brace X-ray now they took this first off, and he's curved the other way in the brace. We haven't made any changes to the brace. Nothing's changed, but now his balance all of a sudden just changed. I haven't seen him yet. I believe I'm seeing him tomorrow. So that's a interesting, case where we have a brace that's giving good correction. Things have been working well. His balance is good. Then all of a sudden now we're seeing this deviation in the in-brace X-ray that's, a little more unusual. So we'll evaluate that tomorrow and find out. The other part is his out-of-brace X-ray taken, here, that one in the middle of the picture right now. His out-of-brace X-ray is very balanced and stable and straight and looks wonderful. So now we're going to evaluate and kind of see what, work with the doctor and kind of figure out what we want to do. Do we need to modify the brace? Is he wearing it wrong?
No, but before we get there, right? I mean, I think it's important to understand we haven't changed the orthosis. The out of brace X-ray looks perfect. In brace he looked very balanced, but we are seeing this in brace deformity. So first, I wonder why another in brace X-ray was taken, but this is throwing us all off.
Yeah, Amit, can I say something?
Sure.
Just flip the second and the third X-rays, because we are seeing the first X-ray as a PA, the second is AP, and the third is AP. So don't worry, the brace is doing a good job. Just flip the X-rays and that's it.
Yeah, you're right. The pictures are reversed.
We just got this today, so that's why we thought it'd be interesting to talk about it. So we know that. But what about
always happen?
But what about the last X-ray? Do you think something's going on where the patient, we're having this kind of reaction to the same brace?
Sometimes it depends of how was your score of the flexibility factor. If the flexibility factor was 100%, you are creating a curve to the other side. So if you have, in this case, left thoracolumbar, and it's 100%, it's going to be right thoracolumbar with the same amount of cup angle. So in this case, you can reduce the forces and just keep it in neutral. So we are exceeding and using more flexibility factor that is necessary.
Got it.
Yeah, that makes sense.
Any other thoughts? Bill, Dr. Patel?
That definitely makes sense, what Dr. Gomez said, in the sense of, it seems like it's creating an overcorrection. But the fact that when he's out of brace, he's still in a good position. Bracing is not my expertise by any means, but it looks like you guys are doing an awesome job. Maybe just pull back on the reins a little bit on the amount of tension there for a little bit.
He's very good at pulling straps tight. You just need to have him relax a little bit.
Yeah. Maybe he was trying too hard in that brace to make sure it looked good, and he overcorrected.
So do you think in this case we should have told him to keep the brace a little loose? I mean,
yeah, I think so.
Tell him if he overcorrects, he's not going to get out of the brace.
I believe that the key is don't look the X-rays. Take pictures from the patient without the brace. Allow the patient to rest 6 hours or so. So the information of the brace is not into the new pictures. So the soft tissue will be relaxing, but if he's doing a good job with the therapy, that overcorrection that I don't like to use overcorrection because it's using the flexibility factor more than it should be. It's achieving a better correction using in full the flexibility factor. That's so important to classify, to measure the flexibility factor. If it's 50% and the patient was 50 degrees, we make a prognosis of is going to be with the brace in 25 degrees. But in this case, the patient was so flexible that maybe you are creating a curve to the other side. So yes, she doesn't need to wear the brace as tight as it is in the last picture, and take the whole pictures, full body pictures, half body pictures, allowing her to rest with the brace on and see what happened.
Great, thank you. Any other thoughts, Dr. Patel? Tracy?
No, I mean, I think that's very reasonable. Obviously, in certain situations when they're very flexible, this can happen. But that means that you've got an ideal patient that you can make a very good difference with.
Yeah, we'd like to see, we do see it sometimes where we have someone that, going through therapy, going through the bracing, that everything improves and we end up in a better spot than we started. I know a lot of times we are trying to prevent things from getting worse, but, ultimately everybody would like to see it get better. So.
Great.
And
Guys,
the last comment, I'm sorry, I'll make the last comment. In this case, if the patient is in great alignment in overall and intersegmental alignment, I will start reducing the doses of the brace and checking every 4 months, every three months, and see what's happening. What's happening in Colombia? I really don't care how old is the patient. I am taking or I am winning the brace if I see a great result at this patient, as this patient, and if the patient is well aligned, well balanced, and stable. Of course, the therapy exercises comes to the most important part of the treatment, as Dr. Patel say, to the rest of the life of the patient.
Great. I think we're seriously out of time. I think it's been a great discussion. I would like to thank everybody. Dr. Patel, again, thanks for making time 2 times in a row, 2 weeks in a row. I know you're a very busy guy. So are you, Bill. And Miguel, thank you all the time. I know you do a lot. We work together a lot. As a matter of fact, guys, you don't hear about him as much, but he's part of our team, and we work closely. We share information. And Tracy, of course, last night when we had our conversation, Tracy was just leaving clinic at 9, making his 1 hour drive to his home. So I know everybody's very busy. So thanks for making time. Thanks for letting me extend this a little bit more. I think this is going to be great help to everybody out there. Thank you.
Thank you. Thank you.
Thank you.
Thanks so
you.
much.
Take care. Bye now.
Bye.
Bye.